So now let's take a couple minutes to talk about some of these additional variants. And again, if you understand what we've been talking about this whole time in terms of, the physiology going on with the immune system, then a lot of this is going to make sense. So going to interleukin 12 receptor deficiency, we kind of already hit on this when we talked about antigen presenting cells activating macrophages. And so you can see here, again, we have our antigen presenting cell. Okay, so this is our antigen presenting cell. And remember, this antigen presenting cell, it can present its antigens to T cells, right? So we have a T cell here that it's presenting its antigens to. And remember that this T cell here is typically going to be a naive T cell when this presentation happens. In other words, this T cell has never been exposed to this antigen. This antigen presenting cell brings this antigen into the T cell again because it's an antigen presenting cell. And the reason that I'm going through all of this is because if you understand this process, then you can understand what happens in interleukin 12 receptor deficiency. So the macrophage now is going to release interleukin 12, right? We talked about this before. So this macrophage releases interleukin 12 when this binding occurs. So interleukin 12 goes over to the T cell, and then the T cell, of course, if you're going to release interleukin 12, right, there's got to be a receptor here. So this T cell can bind this interleukin 12. Then what does the T cell do? Then the T cell says, okay, macrophage, I see what's going on. You want me to go down the T helper 1 pathway, right? You're basically telling me, this antigen presenting cell is telling this T cell, hey, I want you to become a T helper 1 cell. Why would it do that? Well, it's probably concerned about an intracellular type of organism. What is a classic bacteria that's an intracellular organism? That's going to be Mycobacteria tuberculosis, right? We've talked about this, a few times now. And so this macrophage is essentially saying, look, I want you to become a T helper 1 cell. Okay, so that's why it's releasing interleukin 12. Now, again, we have to have the interleukin 12 receptor, right? That receptor, the interleukin 12 receptor, so that we can even get this process to happen at all. Now, typically what the T cell will do in response to that is it will activate this macrophage and say, hey, you're doing a really good job here. Let's activate this macrophage so we can kick things off to fight off this pathogen. Okay, so it's going to activate this macrophage, which is what we see in tuberculosis, and it's going to do that primarily through the release of interferon gamma. Okay, again, and this is the whole process. If you understand this process, this should all make sense to you. So now what happens is, in this interleukin 12 receptor deficiency, if I knock out my receptor, right, I can't get this interleukin 12 to bind to the T cell. I can't get a T helper 1 response because I don't have this binding to stimulate the response, and I don't get interferon gamma released because this T cell never got that signal from the macrophage or from the antigen presenting cell, right? And so that's the whole concept. So again, if we look at this, interleukin 12 receptor deficiency, right? No interleukin 12 receptor. What do you see in these patients? Typically, there's gonna be younger patients, typically, 2 to 3 months of age that present and they have disseminated TB. You can also see this, especially if it's in older patients, you can see this too with Pott's disease, right? Where you have the TB essentially kind of infiltrating the spine. But the idea is these patients are predisposed to intracellular infections that normally would have been fought off with the T helper 1 response, going back to our T cell video. And the classic one here is going to be Mycobacteria. And again, how would you diagnose this? Well, look, interferon gamma is going to be low. This should make sense to you. Interferon gamma is This should make sense to you. Interferon gamma is low because we can't stimulate this process to occur. The mechanism is essentially broken pretty early on here at this initial step. Okay, let's talk a little bit about chronic mucocutaneous candidiasis. And there's actually a lot we could talk about for this, but I don't want to get off of the road too much in terms of what we really want to focus on. What we really want to focus on is in board questions, what are the things that we're going to see that are going to call our attention to this? And it's pretty straightforward here. We're going to see recurring or refractory candidal infections, particularly mucocutaneous infections. What does that mean? I'm not talking about infections of the bloodstream, right? If you have endocarditis from Candida, for example, that's more of an issue with neutrophils. When Candida gets into the blood, that's a neutrophil issue. Okay, then you're thinking more of a neutropenia. That's going to be more of a hemonc thing, right, in general. But that's the way to think about it. If Candida's in the blood, that's a neutrophil problem. If Candida is infiltrating the skin or the oral mucosa or the esophagus, that's going to be more of an issue with the T cells themselves. And I'll explain this in a second when we look at this test here on the bottom. Normally in a board question, if they're asking about this disease, they're talking about very low levels of the RE protein. And I think we talked about this a little bit in the T cell video. Also, you want to remember this is going to be due to a defective interleukin 17 or interleukin 17 receptor. Some associations are made with this as well. And I'm not going to go through all the pathophys here to explain it because like I said, it's just not as high yield, But the point is that we have a lower response to candidal antigens. Now, the way that this is sometimes diagnosed is we can inject candidal antigens into the skin, and what we're looking for is some kind of response. It's kind of similar to what we do when we do the TB skin test. And just to give you an idea of what we're talking about here, so when I inject these candidal antigens, I might get some of these antigens binding to T cell receptors. I might get some of them even potentially binding to macrophages. And the idea here is when there's this binding, we already talked about this whole process here, right? The antigen presenting cell can present the antigen. This T cell may or may not already be activated. And the point is these T cells will start to release interferon gamma, like we just talked about out here, the same mechanism where they're going to release interferon gamma, and then this interferon gamma is going to activate this resting macrophage. Like we just talked about here, that interferon gamma is going to get released, stimulate this macrophage to become activated, and that macrophage is then going to release cytokines that will eventually result in some induration here, right? Some bump on the skin. And that shows that this patient is able to essentially identify candidal infections, and we're able to make an immune response to that candidal infection. Now, if a patient has this test done and there's no induration, then we would be more concerned that this patient potentially is more susceptible to a candidal infection. So that's what happens here in chronic mucocutaneous candidiasis. Again, we would have an absent cutaneous reaction to candidal antigens because our body is not well equipped to fight candidal infections, and that's exactly the problem here. So let me ask you, just to add some layers to this, now that we know kind of some of the players involved, right? We have T cells involved that are going to be involved with activating macrophages. Let's just say that we had a patient that had SCID, right? So we talked about this already, severe combined immunodeficiency. So if I had a patient that had SCID and I gave them an injection with the candidal antigen test, what do you think would happen? Do you think this patient would get an induration of the skin? Right? And so the answer to that is no, right? These patients should not get indurations of the skin because these patients don't have T cells. So they are not able to initially bind the antigen to the T cell receptor to then get that T cell to eventually bind to a macrophage and then release interferon gamma to activate the macrophage so that we can get a localized inflammatory response and an induration of the skin. They don't have T cells, so this process breaks down very early. What about now if I had a patient with HIV? Okay, so if I had a patient with HIV, let's say they had a CD4 count of 700. Okay, I'm just making up a number. If I had a patient with HIV that has a CD4 count of 700, do you think that they would develop an induration of the skin? And the answer is they should, right? Because they have an adequate number of CD4 cells, right? 700. And so they are able to produce this response. So barring any other defects, right? They have CD4 cells that are able to help get this initial process going. Now, if I had a HIV patient, on the other hand, that let's say had a CD4 count of, 50, okay, so if I had a patient that had a CD4 count of 50, on the other hand, this patient would not be able to generate the appropriate induration or any induration at all because they have very few CD4 cells. So the cutoff, like we always say, CD4 count less than 200 is when you start to think about more of the immunocompromised state of an HIV patient. And that goes hand in hand with some of these tests as well. Now, last question. What about a patient that has Bruton's X-linked agammaglobulinemia? Okay, so I'm just going to put Bruton's up here. What about this patient? Will this patient have an induration? And again, you have to just think about it. When we are answering these questions, these are all questions that are integrating a lot of the knowledge that you have, right? And so you think about, okay, what's the problem with SCID? No T cells. What's the problem with HIV? No T cells, unless I have a high CD4 count, right? If I have a CD4 count less than 200, then I have very low T cells. That's the same problem with SCID, low T cells. If I have HIV, but I have normal T cells, maybe I'm being treated adequately, or I don't have severe disease, in that situation, I should have a normal response. In Bruton's, what's the problem? The problem is I don't have B cells, okay? If I don't have B cells, will that prevent this process from happening? The answer is no, right? Because there's no B cells here, right? We have T cells that are binding to macrophages to have a localized inflammatory reaction to get an induration in the skin. There's no B cells anywhere. Now, B cells will be helpful for immunoglobulins, right? Things that we've already talked about, class switching, memory responses. But in this particular situation, it shouldn't have an effect. You should expect to have some induration with Bruton's as well, right? Because the T cells technically should be functioning in Bruton's X-linked agammaglobulinemia. Okay, last one, IPEX syndrome. So IPEX syndrome is due to a mutation in the FOXP3 gene. Now remember, we talked about this when we went through the T cell video. We said there's these certain cells, these are the regulatory T cells. Okay, so the regulatory T cells. And these regulatory T cells are going to kind of be the opposite of the inflammatory response. Essentially, these cells are trying to keep things under control. They don't want things to get out of control, is another way to think about it, right? They want to keep the inflammatory response in check. And so the way that they do this, these regulatory T cells, is they're going to release things like like TGF-beta. Remember, TGF-beta is going to help kind of either cause chronic inflammation or kind of just slow the overall process of inflammation from happening. And the other substance they're going to release is interleukin-10. So both of these are going to kind of quiet down the immune response. And regulatory T cells are particularly effective in this if we have a response to our own cells, our own self-antigens. This is why we went through the process of negative selection to begin with. And these regulatory T cells are marked, right? So they're CD4 positive, CD25 positive, okay, that's particularly high yield, and they're FOXP3 positive. Okay, so this is kind of the classic markers. Now you can see CD4 positive on a lot of different cells, right? CD4 positive cells can turn into T helper 1, T helper 2 cells, but you can also get regulatory T cells from CD4 positive cells. That's the point. They're coming from that cell line. And the thing that distinguishes them really is going to be the CD25 positive and FOXP3 positive, which is actually all up here. So the point is, if you have a mutation in the FOXP3 gene, you might see a pretty significant drop off of those T cells. In other words, those three markers telling you that this is regulatory T cells. The point here is other T cell lines should be intact. So if I did a candidal antigen test on a patient that has IPEX syndrome, we would expect to see an induration because other cell lines are intact. It's the regulatory T cells that are affected. What is the presentation like in IPEX syndrome? And I didn't put a ton on here because I wanted to kind of talk about it. But the first thing is it typically is going to present very early. Some of these different pathologies we talk about, it doesn't really present until, 6 months after we kind of lose mom's antibodies. But with IPEX syndrome, things are going to start off very early on because the issue isn't that we don't have antibodies, right? We have antibodies. We're able to make new antibodies. The issue is that our own T cells are not regulating the immune response. So we can actually have, T cells in our body attacking our own cells, and there's no one in to kind of stop things and prevent it from getting any further. And that's the point here. So if we're attacking our own cells, we're thinking more of an autoimmune phenomena. And if you just remember IPEX syndrome with autoimmune conditions, that can simplify this dramatically, right? Because you know that the regulatory T cells are defective because of this mutation. Now, the classic things that you'll see are things like type 1 diabetes, right? And that's, again, our own cells attacking the beta cells in the pancreas. You can think about things like thyroid disease. So it could be hyperthyroidism, hypothyroidism, right? Thyroid disease. And these patients can have things like autoimmune hemolytic anemia. They can have ITP, which we'll talk about all of this in the hemonc section. You can see these patients with neutropenia as well. And that's because we're attacking our own cells. And like I said, no one is there to kind of keep things under control. And so in these infants, what you'll see is they might have failure to thrive. Okay, so these infants might have failure to thrive because our own cells are kind of doing a lot of the damage early on, and this can be dramatic in these early stages of organ development.